Okay, so as y'all can see, today is Watermelon Day. There were also some other very funny holidays for today that I just couldn't possibly say without laughing out loud. So we went with watermelons. Oh, there he is. All right, so announcements. If you want to give them, you are more than welcome.
Oh, I'll help. All right, remember there's free CME. So just make sure you fill that thing out. I sometimes forget, but try to get it done and you get credit.
And videos, please.
Yes, and if you don't mind turning on your video, I was just looking, we have all kinds of watermelon behind us.
It's Watermelon Day.
Okay.
I'll remind me later to tell you what other days it is.
Perfect. All right. And so, yeah, please, if you don't mind, turn on your video. It makes it much more fun for us.
And let us know if there's other people in your room so they also get their free CME.
All right. Coming up, we have some great things. And I think the person who was supposed to speak today actually rescheduled the mirror. But just remember, next week, we have somebody from our transgender population clinic and Troy Weber Brown, and that should be a very interesting talk. So we're looking forward to that. The following Tuesday, on August 2nd.
No, that was yesterday.
All right, motivational interviewing next week on August 16th. So lots of fun things coming up. We've got John Cole coming in a couple of weeks as well from Hennepin. So lots of really good talks. Remember, if there's anything that we can do to help you, please call us. You can reach out to Aaron first or us first, doesn't matter. Just give somebody a call. We're just happy to help you. All right. So she keeps acting like she's going to talk. And so, but yeah, remember that there is the Center for Opioid Resources and Education Core. Basically everything that we do is going to be on there at some point. It's a little slow getting on there for us because getting some of these things done, but it just keeps moving forward. So please feel free to check that out. And again, the addiction podcast, I think we just released something on
the common questions or pearls with buprenorphine, focusing on inductions and urine drug screen things.
Some of the common questions we get about some of the inductions and some of kind of how we tend to handle those things. So it's kind of an interesting talk. So feel free to check that out.
Next week and the week after, we're going into a deep dive of neurobiology relating to sugar addiction.
If that was really a thing.
You know what, when it's a whole chapter, I know Danielle knows this because she read the book and talked to me about it. A whole chapter in Sam Quinone's second book, The Least of Us, he goes way into it. Like, it's really cool when you hear like such an awesome person use the same things we use.
All right.
You feel smart.
Yes. And again, please make sure that when they send you that survey that you please answer that. It's just helping us kind of continue to improve what we do for you guys and the talks that we pull together from people. So keep that in mind.
Do you think our Zoom is wrong?
Zoom? No,
because you grabbed the
I was going to back it up a little. All right, today it's Dr. Heather, and she'll be talking a little bit about some of the perioperative stuff. This is a talk that we just put together recently. So it's all you, Heather.
All right, and we have some good patient cases thrown in, and one that's not officially in here. I should have maybe added it, and I didn't, but we'll talk through it because I actually have follow-up information now. So the general goals, and we're talking about perioperative management, I mean, really, if it's anybody, is you want to make sure a patient has adequate anesthesia. But if it's a person who is on MAT, MOUD, on buprenorphine, you really want to not have that person relapse because they needed some type of postoperative pain management. Biggest thing, and we'll probably mention this a few hundred times, is really setting that expectation for the patients. Is you're not going to set the patient up for failure. You will not have any pain. I mean, you're getting surgery, you're going to have some pain. And so it's just kind of setting that expectation there. And then you really want to just make sure we're not, creating additional risk, and then having a lot of good communication. So the key questions that come up and we've heard and we've asked is, what do you do about buprenorphine? How much pain relief does it actually offer based on how many of the mu receptors it actually covers? And then what is the affinity compare? Sorry, I drank that pop too fast. What is the affinity? How does it relate to how other opioids bind to the receptors? So is it possible to override them? And then depending on the surgical level, we call them major, moderate, severe. It's actually universal now. And so what does that mean for what you do with the buprenorphine? So here we go. Here's the answer. There is no literally official case-controlled, double-blind, placebo-controlled academic answer. There are a ton of research studies, case control studies, meta-analysis, and there actually is an expert consensus now out there. About 3 years ago even, there were lots of different ways that people handled how they did this. So historically is, we would hold buprenorphine. I don't think we ever did that, but historically the recommendation was we're going to stop your buprenorphine leading into surgery. You'll get your pain medications following surgery, and then we will just, transition back because they are going to have more opioid receptors open, so you can put other better pain meds in there. So the articles from not that long ago actually really kind of contradicted themselves. And you can kind of see here's 4 articles and kind of the different pools that they all fell into. People said it's difficult to have pain control if you kept buprenorphine. Some people said it's manageable if you continued it. And some people said if you stop it, regardless, even tapering it, you have an increased chance of illicit use and or relapse and or all those complications. So the fear is, can you treat their pain while they're on buprenorphine?
Can you?
Can you? So the science, buprenorphine, as we know, is not a full agonist. The full agonist is like your oxy, it's your heroin, your methadone, all those things. Buprenorphine works well as an MAT or MOUD because it is that partial agonist. It binds to the receptor, as you can see, very, very, very tightly, in which it then pushes off all the other type of opioids. So it binds to that receptor 1.7 times higher, so stronger than hydromorphone, and you can just kind of see way stronger than oxycodone's binding. So it's not that there isn't an ability to push the buprenorphine off, it's just, it's not as strong to push it off as it is to, put it on there.
Well, and really the key is what you pick to use post-op. You want to pick the ones that will potentially push off a little bit easier or attach those mu receptors, and they're harder to push off. So again, those hydromorphones and morphines.
Yes. And, buprenorphine actually does slowly leave the body. So it in a way acts as more of a long-term pain medication, which is why patients with chronic pain can be on buprenorphine products. The Belbuca, which is very similar to the, Suboxone or the other buprenorphine products. And then there's the Butrans patch. In the liver, buprenorphine is completely metabolized to norbuprenorphine, which also it has a little bit of activity. And interesting, and I love this because we talked about opioid-induced hyperalgesia, and people who are on pain medication, they actually get more pain over time due to that weird, bizarre reaction thing that can happen. Buprenorphine actually antagonizes, so completely blocks that kappa receptor. And it's felt that kappa receptor is what, if you bind to it, is what causes the opioid-induced hyperalgesia. So we're hoping, there's some discussion out there about how we can better, take advantage of that. Now, there isn't any great studies that say in order to have really good pain management, you need to have this many receptors occupied. No one goes out there and says that. Do you want to talk for a while?
Sure. We're losing Heather. So really it's about receptor availability. And I think that, again, we just were kind of talking about that is like how many of these receptors are actually open. And if you look, just as you look from 1 milligram down to 32 milligrams, you can estimate the receptor availability. So if you look way up at 32 milligrams, which we rarely use, maybe 2 to 12% will be available as opposed to at 1 milligram. You've got the majority of those still open. Really, most of us are living right between about 8 and 16 milligrams. And so really,
we are?
Yeah, we are. That's kind of where we all live. And so in that range,
our prescribing,
there's still probably a quarter of those receptors that are open. Now, on the right side, it's actually kind of the flip of that. So if you look at percentage of coupled receptors per dose, if you go to 32, again, 85 to 90% of those receptors are occupied. And you can see it kind of comes down quickly in that really at about 8 milligrams in drops. And so in the old days, a lot of times they'd say, well, try and get the patient down to 8 or 12, and then do surgery because there's receptors open. But again, that has changed. And so we'll talk about that.
Yeah, and that's kind of where we've always said, that 8 to 12 to 16 is kind of that sweet spot for protecting patients. If they're on 16 milligrams and they go out and use, the chances them overdosing on top of it is less. Now, again, that's changed, like Kurt just mentioned, especially with fentanyl in the world. But
so what does that mean? So this was a study by Komatsu. I said that pretty well, in 2022. So this is really recent. And what they really looked at is when they took patients and they continued their buprenorphine when they had surgery and used other opioids, was that associated with respiratory depression? In fact, it was not. And it was actually associated with lower incidence of respiratory complications, as you can imagine, because not only does the buprenorphine give you some pain control, but it also doesn't activate those receptors in the same way. And so really holding the buprenorphine, really is what carries more significant risks. And that was a study by Weiss in 2021. And again, one of those the biggest risks is really relapse and overdose. Now, patients that are continuing on their maintenance doses post-op actually have lower patient-controlled opioid analgesia requirements. They in fact need less pain meds. Again, we often, I think that buprenorphine doesn't give us a lot of pain control, but in fact, a lot of the studies have shown that it actually can be equal to morphine in the pain control that it gives. Patients, unfortunately, who discontinued their bup, they had about a 50 to 90% chance of recurrence or death. So relapse or death. So it is really significant, and we just don't stop it typically anymore. I literally just came out of a patient's room just before I sat down, who asked me these very questions because she's having surgery in September. And I actually went through all of this data with her, explaining why we don't stop it now. She had 2 babies and they tapered her down during those times years and years ago. So what does this mean? Well, again, perioperative management of bup, it's really a lot of the data that we have, or a lot of the things we have, are just case reviews. And so they look at cases where they've watched patients, and the case reports that are available support that support discontinuation. But 2 case series actually, and one of them a prospective match cohort, they all supported continuation. And so there are some people out there who still think we should be stopping it, but the majority of people are still very much in the last couple of years saying we should not stop it. And in fact, many of these at the end said, and you can read at the bottom, that it's unnecessary and maybe harmful to stop. And really evidence suggests that buprenorphine probably adds to what the other opioids do as far as pain control.
So it's interesting you mentioned OB, because about 4 years ago, I had a perinatologist say, like in the note when they had their consult, and mom was on Suboxone and I touched it, hadn't changed it, to say that, told the patient you should really taper it down off of your buprenorphine, you shouldn't be on Suboxone at time of delivery and all the things. And then of course I had to have a conversation with this OB. I'm like, please don't contradict what I am saying. So then actually I just got a new perinatology report back on a different patient who's pregnant and on Suboxone. And it said, we recommend maintaining your doses. And in fact, in the 3rd trimester, your doses might need to go up. So it was like a very different, canned thing that they put in their notes, but it was just very different from the same provider, actually the same perinatologist. So that was cool.
Okay.
So another study, these are just kind of quotes from these studies that have all kind of happened since that last big chunk. This one says it's almost always appropriate. It's rarely appropriate to even lower the dose. And then it can have similar clinical analgesic efficacy as the full agonist. Another meta-analysis, not very large, 20 patients. What happened? 12 of the 15 were completely stopped or continued, 3 cases where it was discontinued early on, and then 2 cases where it was discontinued just right prior to the surgery. And you can see the patients who were discontinued, a lot more difficulty. They needed a lot more referrals to help with management. The cases where it was just recently stopped, really, really difficult in getting pain control, needed much higher doses. And so the whole adage that you should taper off so we can adequately control your pain actually meant that they still needed even more pain management, or more pain medication regardless. Patients who are at the highest risk of overdoses, this is kind of understandable, but the 20-month mark was really kind of the big cutoff. And so patients who had not been on buprenorphine for 20 months yet, so we're talking around that 2-year mark, had the highest risk of relapse and death if they were stopped or tapered down for surgery. If they had any inappropriate or positive urine drug screens recently, and if they were discharged without that close follow-up with their provider of their buprenorphine. So what do you do if you have a patient who's coming into the hospital, they need surgery, they appear to have an active opioid use disorder, or they have one that maybe hasn't presented itself, or they're at really high risk of getting one? So in general, if you look at hospitalized patients, a lot use substances. So I know I'm just dying. Don't drink the pop. So about a little over a third of patients in the hospital, regardless, use tobacco. 20% of just regular hospitalized patients for anything, pneumonia or whatever, use alcohol in higher levels or have an alcohol use disorder. 8% use other illicit substances. So really, we don't know what percentage of patients who come into our hospitals actually have opioid use disorder, especially if they're having surgery. You know, if it's an acute trauma, often they're going to get pain medication, whether it's in the ambulance, in the ER. So you'd really have no idea what their baseline was. And if you have, and just not treating their pain. So if they've been using opioids chronically, they've been using, you know, whatever, their tolerance is going to be up, they're going to have lower pain control, and it can just totally exacerbate everything, not just their opioid use disorder, even if it's not been diagnosed, but also just other underlying medical conditions. They get readmitted more, and then they have more overdose. So what do you do with that other patient? It is safe to start any type of MOUD while they are hospitalized. SAMHSA actually recommends it. At 6-month follow-up of patients who were start at hospitalization, they maintained recovery longer. They followed up with their provider more. They actually showed up to post hospital follow-ups. And so SAMHSA recommends, if you have a patient in the hospital, it's really important to screen for this. And it's really important for hospital providers to get comfortable with doing buprenorphine, not just trying to figure out how to manage them through surgery, which we often get calls on. But if you have a patient in the hospital, you should really be starting it. And even having a short period of time, like even just that hospitalization, getting buprenorphine product or an MOUD will help that patient's longer term survival. Even if they don't follow up, even if they're lost to follow up for a long time, they still have less death because they've been exposed and they kind of know that there is this help there. So if you're looking at these 9 studies, what did they do? This is patients who, again, were at high risk. They actually started patches of buprenorphine prior to surgery, and then they maintained it 1 to 8 days after. So these are more your high risk patients. And they actually had very similar lower post-op pain control. They didn't need as much post-op, other pain medications. They didn't need the PCAs. They didn't need as much oxy. And they actually had pretty decent patient satisfaction and no increase in side effects. So it is, a thought out there is, should we do more buprenorphine post-op, especially in larger surgeries, to kind of minimize that risk of an acute prescription becoming a chronic long-term opioid patient? So can you do this as a treatment post-op for pain? So if you look at buprenorphine versus morphine in this study, there was 0 difference in pain, respiratory depression, or sedation. So initially I was like, you'd think that there'd be more respiratory depression in the morphine patients versus the buprenorphine. These patients were all in the hospital and all being monitored, but it was just as efficacious as the morphine was. And that's a lot of patients that they reviewed. 2,200 patients is quite a bit. sublingual buprenorphine just as effective in that study. So again, here's 2 studies, actually 28, 29 studies if you want to go there, that just showed it was just as effective for treatment of acute pain as using a full agonist. Now, this was interesting because this study said tablets and IV is good for post-op pain, but you really shouldn't use patches unless it's a chronic pain. And there's differing studies out there on can you do this and what should you do at hospital discharge. Kind of the consensus when you read a lot of these in the anti-transdermal during the acute phase is that you lose some of that, acute. Buprenorphine tends to that 4 hours after taking your dose gives that pain control more than the long-term, the longer acting. So having the IV, having the tablets where you can dose it more frequently offers more pain control in those studies, whereas transdermal, you're kind of at that baseline, which would be, an option if they were going to be on chronic pain medications, or you'd anticipate them needing it longer, like a burn patient. So what does it all mean? Before I get to that, I'm going to talk about my patient. So I had a patient recently, alcohol use disorder diagnosis, no history of opioid use disorder, no history of opioid use, has been in recovery from alcohol use disorder like 8 years and literally does not want any type of opioids. Had bilateral hip replacement surgery and had, all the nerve blocks, did ibuprofen and Tylenol, was uncomfortable for a day, but definitely did not take any type of opioid product, adamantly refused it, would not take it. 5 weeks after the hips, had a knee replacement. And so the ortho was very anxious about this, saying, knees are more uncomfortable, like not sure how we're going to do this. So that's where I got involved. And I said, well, there's really no good research out there about what do we do about pain in a patient who is at risk. And he flat out said, like, if I take one, I will like it. And then I will have to go down that road again. And so I called him in, and we can have an off-air discussion about the product. I actually called in straight Subutex rather than, any of the other options, mostly because it was easier to get it covered and whatever. But anyway, I called in 10 of the 2 milligram tablets. He said on post-op day 1, 2, and 3, in 3 days, he took a total of 5 of them. And then a week later, after his first physical therapy appointment, he took 1 more. That is it. Said his pain was actually better controlled than with the hips, and hasn't taken any more. Only complication was the constipation, which I didn't even think about because it is an opioid. So mental note to self, call in some type of a stool softener. But my N of 1, it was quite successful. So if you look at the ASAM practice guidelines, these are still fairly new. 2020 basically says do not discontinue methadone or buprenorphine, but do know that you are going to need higher potency IV full agonists, kind of like Kurt mentioned, using the IV fentanyls, using the Dilaudids. Oh, okay, Isaac, do you have a question?
Yeah, thanks. I'm going to have to leave soon, so I just wanted to get it in, and it kind of dovetails with your case. So I guess my question is we see lots of alcohol use in the hospital, lots and lots of alcohol use, and oftentimes there's trauma related to alcohol use. And I'm kind of curious your thoughts on sending people home with bup if they actually have active alcohol use disorder. They may have, 10 broken bones, and we're trying to get them through this recovery, but they also, maybe aren't interested in treatment, or they don't really see their alcohol as a problem, but clearly they've had issues with it. Do you think it's safe to send people home just on bup in that situation, or would you just not send them home on anything? I guess I'd be curious. I don't know if Charlie, you had any thoughts either, but I find that we're in this place of really wanting to keep people safe and really wanting to treat their pain. And I sort of lean toward it's probably safe if alcohol is their drug of choice, but I'm also concerned about the combination of the alcohol and the bup.
So that's a great question. So personally, it's that whole, you don't want to not treat a patient's pain, like if they had, all those broken bones and they're leaving the hospital, I guess, it's that transition between day 3 and 5 of the acute pain medication is where it's like that tissue injury, as you know better than I do. If they're needing to go home with some type of post-op pain medication, and it's what you would send anybody home with, the buprenorphine is still going to be way safer than sending them home with oxy. Charlie's nodding. Good answer, Heather.
Well, and I think too, think about all the patients on chronic pain meds, especially the elderly over the age of 65 or 70. That's elderly. 70. Let's go with 70.
You were going to say 60.
I was going to say.
You realize you're 61.
Yeah, but I think that we have all these patients over the age of 70 who are taking chronic pain medications, and a significant number of them actually drink alcohol. And which is a conversation we all need to have with those patients, but they actually reasonably do well. And so again, buprenorphine, much better choice. So I would agree with Heather. And I think Charlie, if you want to chime in.
I think you guys, I totally agree with you. The only thing I might add is different people have different patterns of drinking. And I think you can get a pretty good assessment talking to the patient about what their pattern is. And yeah, the heavy binge drinker who's going to go on like a major bender and get their blood alcohol level up to whatever, 0.3 or whatever. I'm worried about that person no matter what. But kind of the steady drinker who's not like going on, case of beer a day binges, I might be more comfortable giving them post-operative opioids, including buprenorphine. So it kind of depends on the pattern of drinking. Yeah. And then of course, yeah. So I guess I'm on the same page with you. And this has been happening for decades and decades and decades. And there's not like an epidemic of people dying of post-operative opioid alcohol overdoses, although it probably does hurt outcomes. So yeah, I mean, I agree with Heather and Kurt. Moral of the story. Thanks for drawing me in.
Well, and I also think, it's the whole thing, like one use disorder, puts you at risk of another use disorder. And like this patient has no reason to think he's going to like it, but understands that like he actually said, like, I'm the kind of guy, like if I have one drink, it's 10. Like there is no, that whether it's a binge or an all day, like it just, and the thought of having one opioid and liking it when they, in a way, are very similar kind of effects, the downer effect, if you want to call it that, just, you'd hate to set them up for an opioid use disorder regardless, on top of an active alcohol use disorder.
All right.
Okay. So the SAMHSA guy.
Can I just one more quick thing? Ask if there's like a trustworthy person at home who can help control the meds. Because even if you're really drunk, Percocets, it's if you're really drunk and you're overusing the opioids. So if you've got a trustworthy person at home who's like, no, Mr. Jones is on a bender, let's take the pills away. That helps a lot. So I would do that as well.
And I'm sure there's less risk of diversion if you sent a person home with buprenorphine versus Percocet.
Yeah.
I just don't think Percocet should be prescribed anymore because of the registry issues. But anyway, so SAMHSA guideline recommend that most patients continue through the perioperative period because of that increased risk. Now, I guess I would say that if it's a person who's like majorly trauma and they're like obviously intubated in the ICU for a short period of time, I mean, okay, different story. But then you're going to want to restart them after, but that's not the common thing here. So our approach, this was our pat on the back for a half a second, because kind of what we always just mentally thought about for all these years is very similar to what ended up being the consensus. So mild, moderate, severe, like what is a mild pain producing event, sprains, dental issues, small lacs, just treating with simple things, local anesthetics, ibuprofen, Tylenol. Moderate, so minor bone fractures, whatever you want to call minor, small surgical procedures like carpal tunnel, just more the locals, maybe add on some Toradol. And then if you have your severe, so this is like we're cutting into your organ cavity, or large issues, multiple, in the IV hydromorphone or fentanyl, this is going to be while inpatient. You're going to want to do that to override. It can push off with not as high doses the buprenorphine. Now, I don't want to say these are rules, like you say to a patient, nope, you had a minor bone fracture, this is only moderate, because of course, everyone's going to process that injury differently. So it is, of course, important to talk to the patient, make it patient-centered, but kind of like in general.
Yeah, it's funny because I just had a patient call and they're on injectable, they're on Sublocade, but they had a thumb injury, no fracture, no nothing, normal x-rays, and they wanted a bump of their buprenorphine to put on top of the Sublocade. And I was like, no, that's really where we use ibuprofen and we use Tylenol. But if it was a femur, well, now we have a little bit of a different issue. And so,
yeah,
but I think if I was to pick the thing that I've had the most trouble with post-op pain, tonsillectomy in an adult, that was a nightmare, and it was really a difficult case. So,
and we didn't put this in here because, we talked about what we do for patients with, pain after surgery and what we do with their buprenorphine, but we didn't really talk about in here, like the Sublocade. And so I think a big thing, it would be reasonable to add on, shorter dosing over the top, just because it's not as long acting then. But the biggest thing is talking to the actual surgeon and talking to the actual patient. Surgeons will say, you need to get off your buprenorphine, or they'll say, you can't be on this, or I can't control your pain. I don't think they're as black and white as they used to be. Often surgeons will actually just, they kind of panic. They might send you a staff message through the computer, like, what to do. It's different if you are a primary care doctor doing the actual pre-op on your Suboxone patient. Epic actually has a little drop-down thing now. What do you do with buprenorphine around pain? We were talking about this when we presented this before, is that, people don't always read the whole H&P, regardless of the fact that they say they do and get down to the plan. So at the very top of the H&P, write that in there. Here's what I would recommend for pain, and be comfortable maybe having that discussion with the surgeon of, I will handle their pain post-op if you're concerned, if there is that, because you might need to use higher doses of oxy or something. Anesthesia should be also aware that they're on it. No one wants to be blindsided with anything. And then the other common question I've asked in the past, especially just kind of getting into this world, was asking the surgeon, if you were to take an opioid naive person and go through this exact same surgery, what would you give them? Or what would be a common prescription or common pain regimen for that person? And then just understand that you may have to just bump it up quite a bit or double it for a person who's on buprenorphine. So for the intraoperative period, and this is kind of more for anesthesia, but also for surgeons or just anybody in general, using the ketamine, the lidocaine, other forms of local, a lot of nerve blocks, peripheral catheter blocks, tap blocks for the abdomen, Exparel. My patient said, I can't imagine. He's like, I don't know if this worked, because he got Exparel for all of his surgeries, but if it didn't, or if it was working, I can't imagine what my pain would have been without it. So it's kind of the newer thing. It's a long-acting local anesthetic, I guess. Avoid the use of benzos if possible. However, anesthesia is monitoring their respiratory status. I don't know if I'd throw on a Klonopin and then send them home from the hospital, but just monitoring.
One of the things that we'll be talking about coming up, because Isaac has talked about doing a little something on buprenorphine and sedation. And I've been meaning to talk to Isaac, and I'm going to probably offline, but some of the other things when we send people to dentists, and they have some very interesting things they use, including something I ran into recently was Halcyon, high dose. And that's just a really interesting thing. And also some of the interactions with laughing gas. And so these are things that hopefully will come up in a future talk we do. I was going to maybe pair up with Isaac on a couple of those things. Oh. Just so you know, Isaac.
Okay. So kind of the general pain management for patients on Suboxone or buprenorphine, continue it as prescribed unless obviously directed by their provider. May consider QID or split dosing. So again, the analgesic properties of buprenorphine, it's best in that 4-hour window. You're going to get the most pain management in that first 4 hours. And so taking a patient who's on 8 milligrams twice a day and having them split that and making it 4 milligrams 4 times a day. So they're on the same total daily dose. They're just taking it more frequently. Consider other non-opioid analgesics. NSAIDs, I've never, ever considered these after surgery, but I guess they're kind of on the list.
They're on the list.
So a patient taking buprenorphine, so they might need, like we just mentioned, higher doses. So that's kind of that 2 times the average dose to kind of push that, especially taking oxy. It's way stronger. Buprenorphine is bound, so you might just need more. Plus, this is an opioid naive patient versus a patient with tolerance. They're going to need more. Avoid long acting, which is kind of the census on everything in this world right now. Again, the benzos watching it, and then the regional techniques if possible.
It's actually the long acting benzos as well are a bigger problem.
So consider, and this is kind of what I was meaning with the split dosing. Sometimes we will increase the total daily dose. I had a patient who recently was getting like full dental work and implants and everything. And, he was very nervous because the oral surgeon was like, we're going to need a lot of pain medication. This is going to be very painful. And he called me and he's like, what do I do? And this was what, he was on 16 milligrams total daily dose. I just increased him for one. I did a month, make it easy. This is a guy who's been in recovery for 6 years. We communicated a couple times a week. He'd text me, increase him to 24 milligrams total daily dose. And then he just split them. And so he took like 4 milligrams kind of every 6-ish hours. I mean, he knew his dose typically was 16. So he was always taking a little bit more than that. And he actually only kept the 24 milligrams on for about 4 days. And then he himself just went right back to his normal dose. And so a month was a little bit extreme. I just tried to make him not get anxious and me not have to call in more meds all the time. So that has worked. And we'll get to some cases here on that. If they need to leave with some actual full agonist opioids, not giving a lot, it's kind of limiting it, and just set that expectation with the patient. Typically 3 days is where, we don't necessarily need pain meds, but it's okay if you do. Like, don't shame them for having to call you because they're still in pain. Like, make that an okay conversation. This is just a fancy table, if you're really into tables, that basically says every single thing else we just said, just in a fancy table. Okay, this is your patient.
This is actually a guy I saw a couple of years back. And so this would be an example of a case that is a minor surgery. And, a lot of people that I know have had carpal tunnel surgery and frankly have not taken anything for pain. This was a guy who was on Bupe. He was on 8 twice a day, been in recovery for a few years, and actually healthy guy, working guy, busy guy, got a lot of stuff going on. And of course, he came in for his pre-op and had this carpal tunnel surgery and was very adamant he really was hoping to avoid any opioids. And so kind of pre-op planning, I called and I talked to the orthopedist and I made sure that they didn't stop the Bupe, and really advised him on some different things he could do, especially post-op, just to make sure the guy was comfortable. And again, I think a lot of orthopedists nowadays try and avoid opioids at all for a carpal tunnel. And he was really very much for that. And so we just made a plan to hit the NSAIDs, hit the ice. I bumped up his buprenorphine just for a couple of days and spread it out. So we just made it 4 times a day and, cut those 8s in half. And he did absolutely perfectly, had no trouble at all. Went through this like nothing. So, smaller surgeries, again, don't feel like you're going to need to do anything with the opioids. Most of the time you can get it through. His pain was really tolerable, no lapse, no relapse, continues to be in recovery. It's been 4 or 5 years now. This is actually another patient I had in the last year. This is a lady who's been in recovery for 5 years, very healthy lady, locked up her knee. So they're going to do a scope, and they're going to do a meniscus repair. And I talked to the surgeon, and he said, there's going to be a fair amount of pain with this. And I would typically give these patients some pain meds for 3 to 5 days. And so we had a conversation preoperatively about what we would do for her. And she was a little bit nervous about the opioids, but knew she was going to need them. And so again, talked a lot about the Toradol and really anticipated 3 to 5 days and made that kind of like, that's where we're going to probably stop and plan on using a full agonist like hydrocodone. She had previously really liked Percocets, really wanted to avoid those. And I think that you'll find that there's patients that want to avoid the thing that they really enjoyed previously. So she did not want Percocet. And in post-op planning, again, the usuals, the NSAIDs and the ice. And we actually, again, did the same thing. We busted up her buprenorphine to cut those 8s in half and go 4 times a day. But also gave her the hydrocodone, and she just wanted a small dose. And we just did that for 3 days, actually. And the 4th op day, she felt like she could sneak by. But she wanted to bump up her buprenorphine for a few days. And I thought that was a pretty reasonable ask for her. And so we actually bumped her up to 24 milligrams total daily dose. We did that for a week and then went right back to her usual dose without any trouble. And she continues to do well. This probably 6 months ago, right back to work. So nice case.
All right. So my patient, 24-year-old female, presented to the clinic at 27 weeks gestation based on this 3rd trimester ultrasound almost, in withdrawal when she presented from heroin and meth. And so now what? So I'm going to kind of review some of the OB stuff quickly before I get to where we ended up with her. So, which medication? Do we do methadone? Do we refer to a methadone clinic? The benefits is there, we don't have to worry about precipitated withdrawal. She's pregnant, end of the 2nd trimester. So less concerns there, but still there. We didn't want her to have horribly precipitated withdrawal. And this was heroin days, not fentanyl yet. Good data in pregnancy. The downside is that she'd obviously have to go to an OTP at this point, and she lives even more rural hick than Little Falls. So to get to an OTP was going to be a difficult thing. And she didn't have a license. She had no way of getting there unless her parents were going to drive her around. And then, of course, the higher chance of having NOWs and needing a longer hospital stay, NICU stay. So then what about a buprenorphine product with or without naloxone? So Subutex versus Suboxone. The benefit, you can do this in a clinic, and I was her provider, so that was easy. We know that there is less need for longer stays in the hospital for baby, less, morphine needs for baby for withdrawal. Didn't have to go anywhere for transportation except when I was seeing her in the clinic. Without naloxone, so the Subutex product is also a high recommendation in pregnancy, right along methadone. But the Suboxone was less likely to have diversion. And at the moment, she was living with the father of the baby, who is also an IV heroin and meth user, and his mom, who is actually one of the dealers in town. So this is a high risk housing situation where diversion was a very, very real, concern. And downsides, we would need her in some withdrawal to obviously induce her. And again, the plain buprenorphine, higher risk of diversion. What about this retention issues? Methadone, at her point, she'd be going every day for the remainder of her pregnancy and beyond. We weren't going to keep her on daily dosing the whole pregnancy, very frequent right away. But these were all things we had a discussion about or thought about. The combo product, less available data, although pretty much everybody does that. So luckily she was already in some mild withdrawal. So I started her on a very low dose of Suboxone and, got her up to almost dose within a couple of days. And, I talked to her about the difference between the naloxone versus not. As part of it, we did elect to go with the Suboxone. Got her up to 8 TID to help with the cravings and all of that. Plus 3rd trimester pregnancy, especially, the placental breakdown, often patients have to go up. After the first, I saw her 3 times that first week. Then I went to weekly. Every single urine drug screen was as expected. She actually moved home with her parents because, her significant other and his mother were still using. Thank you, Charlie. No. And, she came to every single follow-up appointment, did very well throughout this pregnancy. So obviously planning a normal spontaneous vaginal delivery. This was her first baby, in which case Tylenol and ibuprofen is 99% of the time going to be enough for pain management after a vaginal delivery, unless you're dealing with a lot of tears. Of course, she ended up with a C-section, which is one of the major procedures. So what did we do after we panicked for a minute? Had the discussion with anesthesia. I said, what can you do? And this is when kind of tap blocks were just kind of getting going. So did well with her epidural or spinal or whatever she had. Anesthesia did the tap blocks. They gave IV Toradol right in the OR. And again, after that, for 2 more doses per the protocol, continued her Suboxone at the same total daily dose, but again, divided it into multiple times a day so she'd get that pain relief. The night of the C-section, she got 1 dose of IV fentanyl. That is it. She never needed anything stronger than Tylenol, ibuprofen after that 1 dose of IV fentanyl. And I have had 2 C-sections, so that's amazing to me. I already said that. Okay, so discharged, mom was officially discharged post-op day 3, as typical with C-sections. Baby did fabulously, never had any type of withdrawal issues. Mom stayed in the hospital with baby, but discharged on day 5. Fought with child protection because this baby and mom had been doing so well. There was no reason for a baby to get placed at hospital. Baby went home with mom. She had a negative meconium screen, so baby did not have any substances in her urine in its, meconium except for the buprenorphine. Maintained on Tylenol, ibuprofen, and Suboxone. And we did weekly follow-ups up until that 6-week mark, both to, she's a young mom, a lot of social issues. Wanted to make sure she was okay mentally, physically, emotionally, as was the baby. And then we went to every 2-week visits after that. So, summary. It is not recommended to clearly decrease or discontinue buprenorphine for surgical procedures. Not recommended in most cases to taper it. Spreading the total daily dose over multiple dosing allows, for more utilization of the analgesic properties, and increasing the total daily dose, especially in larger, more severe surgeries, can also minimize the use of full agonist opioids. Pay attention to other modalities. Beth, I will get to, I promise. Nerve blocks, ibuprofen. If opioids are needed, increasing the dose, often doubling the dose of what you would give a person who's opioid naive. And, it is possible to give buprenorphine as your primary pain management strategy in patients who are at high risk. But ultimately, it always comes down to that patient-centered care, team-based approach, communication, one of those things that's so dang hard. So there's a ton of resources here. But Beth, you had a question.
I just want to confirm what I thought was a reasonable, or hope in the future might be a reasonable approach. This is a little while ago, but I was contacted about a case where the patient, pregnancy was the situation. And so the bottom line is an epidural was placed, the catheter was placed, and only the anesthetic agent was used rather than including an opioid. And I think, to me, what seems reasonable, planned or not planned, epidural or spinal, do what you normally do, anesthesia, and then treat the pain on top of that. But let's probably not withhold an opioid on somebody who's on buprenorphine. Or, you know what I mean? Does that make sense, the question? I just want to make sure, because it was done differently, and I think my recommendation would be do what you usually do.
So personally, I had my first epidural went horribly wrong. And so after that, and even with my C-sections, with my spinals, I asked to not have any. I only had a local in my spinal and my epidurals without having any need for anything further. So I think there is this little bit of a switch with the anesthesia anyway in that. I totally agree with you though, Beth, like doing what you always do rather than changing it for that reason.
Yeah, I would say
Okay, so you had it without the opioid, is that what you're saying?
Yeah, I reacted and
yeah.
Yeah.
But I think in general cases though, I would not withhold that because of the bupe. I mean, it makes no sense at all. And I think that, if people wanted to do that, I think that's fine to not use it. But I think for the most part, if the patient wants the best pain control and they think that would help, I would do it just like normal. Yeah.
Okay, thanks.
Yeah. All right. Other questions? Anybody with any thoughts before we say goodbye for the week?
Hi, this is Dave Rossmiller. I was just wondering, is there any role for doing a micro-induction on somebody who is already using or already on chronic opioids, and they end up in the hospital and you want, or even in your clinic and you want to switch them? And my experience has been, I've had multiple patients who've had the typical tooth problems, and so they've had to have multiple extractions, and then they're going through implants, and it's actually worked really well to just give them, you know, like 10 Dilaudid to get them through like 2 days of it, and then they've all gone back to their same doses and done just fine. So it's worked really well. So I'm outside, so I'll mute and listen.
You know, I think, you know, right now, especially with like the low dose or micro inductions, you know, especially in that high risk patient who comes in on opioids, I think that's super appropriate is to start low. We basically do all of our inductions now with low dose because you just never know if there's fentanyl or something else around.
Yeah, I mean, I think that's totally reasonable. I think especially if they're going to have some pretty significant stuff done, I think switching like that is just, I think that works.
Yeah. And then, you know, whether it's Dilaudid or whatever, or splitting the dose and see how that goes.
And I think there really isn't a lot, again, there aren't studies that show what's the best way to do this. I think we're all kind of figuring this out as we go. We're building the plane while we fly it. And I think that if you find something that works for you, I think that's totally fine. It's just keeping that patient safe. Yeah.
Actually, a related question. I have a handful of patients that I've got on like a 2 milligram dose of bup, and then they're on their prior pain meds, and it seems to work really well. They don't call in for early refills as much. They haven't escalated their doses, and I think that little dose of bup just acts on that kappa receptor and keeps them from getting sensitized.
That's an interesting concept.
That is a very interesting concept.
Yeah, when you look at patients who truly need the opioids, and if you add a small dose, that's really interesting. That kappa side of it to try and avoid the hyperalgesia. That's that I've not heard anybody mention that before. That's really kind of an interesting thought.
Getting the insurance and pharmacies to go along with it is sometimes a challenge, but
I'll bet. Yeah, they're great when you try and do two things at once.
Yeah, I wonder, we had a different speaker on in the past who really, and it wasn't Isaac, it was somebody like Isaac that did more of that whole talk on central sensitization and hyperalgesia. We should maybe see if they have any studies or anything on that. That is a great.
How did you think of doing that? Did you see an article at all?
It was actually one of the pain clinics here in the Twin Cities, and the doc had suggested that you could do that.
You should send us their name so we can.
That's interesting. Yeah.
Okay.
All right. Well, thanks, Dave.
That'd be awesome.
Yeah. All right. Anything else before we go? All right, everybody. Well, until next week,